In progress. So that's a reminder to me that we are recording this again today. The one that we did last week is now done. It has been edited and it will be available on our website, on our church's website. So if you want to see that from last week, you're welcome to look at our church website, umcgv.org. United Methodist Church of Green Valley.org. You can look at our website and you can find that. And please don't count the many times I said "ah." I went through Toastmasters and that was the thing you always got teased about, but I was horrified to see how many times I said "ah." So to let you know that we have information about a variety of things going on in the community that we also want to share with you. One is that Valley Assistance Services has something called Your Window into Their World. It's a virtual experience for anybody who wants to know what it's like to have dementia. And we can arrange that through Valley Assistance Services, Chris Erickson, the director. But sign up, I'll put a sign up sheet out here on this table. So if you're interested in that, just put your name on that and we'll arrange that with Valley Assistance Services. I wanted to also say that we're delighted that Prestige is with us as well today. Prestige Senior Living, and Julie Hansen is here with us. Julie, you want to raise your hand? Prestige does have a support group for caregivers on Thursdays at 11 a.m. So there's a flyer about that. Prestige also has a free webinar called Brain Health and Wellness for Older Adults, and you can sign up for that. It is next Thursday, the 26th in the morning, so you're welcome to sign up for that as well. And then we have items for La Posada's programming, including their support group, which also is on Thursdays, and that's available. And Marjorie, is that what you were holding up in the back, wanting to tell me? Okay, things in the back there also for Posada Life. So we're delighted that all of these resources are kind of coming together. Today, after Dr. Hector will be with us, we also want to invite you to just spend some more time in this room if you want with the small group. One of the things that we felt was so valuable last week was the fact that you got together with others and shared some ideas or shared some resources or concerns or worries or whatever. So feel free to do that today. Even though we'll end with Dr. Hector's presentation, if you want to, feel free to do that. We don't want to rush you off and cut that resource off. In many ways, you are the best resource. You meaning those of us that know something of that we face as a health issue in our life. So there we are with, I think, all of the announcements that I needed to make. All right, we also do have this book available, $12, No Act of Love Is Ever Wasted, which is the one that we have recommended. And the list of resources that we passed out last week, Caring Through Dementia, that should also be available to it if it's not. Yes, Chris.
I was just going to say there are some additional resources there on the front tables here this week.
Okay, great. Additional resources as well up front. So with all of that, I'm delighted that Regina Ford with us this week from Posada Life. She's been a part of this passport. She joined us by simply noticing it in the church's newsletter and contacted us and said, can I join? Can I come? And here she is. She's a professional herself working at Posada Life. So she's going to say a few words about herself and then introduce Dr. Hector.
Thank you, Jerry. Welcome, everyone. It's a joy to see this many people in the audience, willing to understand and learn something that impacts most of our lives on a daily basis, especially in a retirement community. I have I've been working for La Posada Community Services for the past 6 years. I was with the newspaper for 20 years, and in my time at the newspaper, I encountered many different aspects of life here in the greater Green Valley area. And my father was here, and as he became more dependent on his daughters, both my sisters here as well, we 5 years of his life. I spent 4 nights a week there. My sister spent 3, and we both had full-time jobs. So it's an interesting journey, and it was worth every minute. I got to know my father in an amazing way, and I'm very blessed and very grateful for the opportunity. And it wasn't always easy, but now that I reflect back on it, I cherish that time. I really cherish that time. But we needed help, and we needed assistance. That's all right. No, that's okay. I started at Passata Life Community Services and realized I had found a niche because I had grown and learned. And I want to be able to assist people who are currently going through sometimes the struggles and the joys of caregiving for loved ones who may not be able to totally care for themselves. And I also have the pleasure of introducing Dr. Mel Hector. Is he on?
I think I am, Regina.
Oh, good. I just want to say a little, Mel is quite a character.
Can everybody hear him okay?
Can you hear him? I've known Mel for several years now, and one of the great things about him is he's very familiar with this topic. He currently is the clinical associate professor in the Division of Internal Medicine, Geriatrics and Palliative Care. He's been a geriatrician for more than 30 years in the Tucson area and has worked at the University of Arizona for the last 3 years. Part of his job has been taking care of patients in the Santa Rita Care Center in Green Valley for the past few years up until 2020. Mel Hector is also a prolific playwright, and he writes plays surrounding this subject in many of his themes. And so I want to let's welcome Dr. Mel Hector. He's going to talk about dementia.
Regina, thank you so much. I can see the podium and I can see the whiteboard, and intermittently I can hear you, but the audio was cutting out a fair amount. So I hope coming back at you. If you are.
We can hear you, Mel.
Oh, okay, good. And if you can't, please tell me. I'm more than happy to repeat myself. I do that a lot. Talking about dementia and certainly looking at the way we handle it and the way we've approached it for the last 30 some odd years of my career, it seems as though we've done a fairly good job of trying to define what dementia is, trying to separate it into various different subtypes according to the medical model, which means looking at a problem the way a doctor would look at it and the way a doctor would divide it up, which may or may not have a great deal to do with reality, but it is the way we perceive reality. So early in the last century, Dr. Alzheimer was investigating a series of cases of people in their 30s who had developed what later became called dementia. And this was a particular kind of familial dementia, ran in families, affected them at a very early age. Characteristic changes in their brains on their biopsy when they died that showed plaques and tangles that eventually became identified with his name as a person having Alzheimer's disease. Now, fast forward about a century, and there are researchers that are incredibly well known on this topic who would insist that there isn't a person in this room, there isn't a person on this planet that will not develop Alzheimer's disease if they live long enough. And for some people, if it runs in your family and it is a familial component and a genetic component, that may mean in your 30s, you will invariably develop Alzheimer's disease. And for the rest of us, it doesn't happen like that. What we have tried to figure out is if it's inevitable that we develop Alzheimer's disease, and at the same time, we're all trying to live as long as we possibly can, then what can we do in our lifetime to see that we don't have that while we're around? And there have been some very interesting answers to that, but I will start by saying what are not the answers? What are not the answers to slowing down Alzheimer's disease or making it not happen, unfortunately, are all of the medicines that we prescribe to treat Alzheimer's disease. And yet we prescribe it. If you came into my office and I felt that you were having early Alzheimer's disease and you were interested in trying it, I might put you on donepezil or Aricept. If I thought you were further advanced in dementia at this time, I might put you on another medicine, and I have some choices. But if you then said back to me, Dr. Hector, is there any proof that any of these medicines change the course of this disease? The answer is no. In 2023, we cannot change the course of Alzheimer's disease or dementia in general, although that has some caveats. What we can do, and Aricept donepezil is a good example. Aricept has been around for some 35 years. It's probably the first medicine used to treat dementia and the first medicine that somebody would be using to treat a dementia patient. And what we have seen, if I put you on Aricept and you have dementia, your family thinks you do better. If I test you for your cognitive ability every 6 months, you don't do any better. And the endpoint is exactly the same. And the only data we have that says Aricept helps people is that their families think it helps people. But you can't prove that it improves their cognitive performance in any way. There are, to be sure, if I put 100,000 people on that medicine, there are some people who will seem to do better. You stop it, they seem to do worse. You start it again, they seem to do better. And maybe there are some people with dementia who are benefited by this medicine, but probably 9 times out of 10, when we start Aricept, before very long, we stop it because it's not cheap and it doesn't seem to do what we want it to do, and it has side effects. So those of you who are really wanting to be on the hot track for a Nobel Prize, come up with something that will change the course of this disease. I will entertain questions at any time, or I'll keep going if you want, but I can tell you what stalls the development of Alzheimer's disease. I'm 75. And if I don't want to get Alzheimer's disease and I ask myself, what can I do to keep from getting it? The things that we know that are proven to put it off are exactly the same things you would do if you're trying not to get heart disease. You would exercise. You would eat right, you would watch your cholesterols, you would watch your blood sugars. If they're tending to go up, you would keep an eagle eye on your blood pressures. You wouldn't drink too much, you wouldn't smoke at all. And if you do all of those things, none of them are particularly attractive. It's not a sexy thing to do, but it will keep your heart strong and it will keep your brain as strong as it can be for as long as it can be. The other thing I would throw in there that has been proven to have an effect is to keep your mind busy. Find stuff that are a challenge for you. Think about it, learn new things, get out of your comfort zone, spend some time with your brain. And those are the things that help forestall the development of dementia whenever it happens that you might be scheduled to get it in your life. And if
there. Sorry.
the other thing that I would like to talk about just in the opening moments, and
Our connection's unstable, so I'm trying to connect to Johnson Hall internet. There we go.
I will hold on. Do you think that's any better?
Yeah, that's better.
Mel, do you have a video button? A camera?
Do you want to use that microphone up there, Regina, so he can hear you better? Yeah, thanks.
Mel, do you have a camera?
I do have a camera, and it says that maybe it's lying. It says that it's on. Let me see. It says it's on, Regina,
Hmm,
but it doesn't look like it's on.
right.
Yeah. So when I click stop video, it turns it. See, you get that. When I turn start video,
Well, carry on, Mel. We're this is very interesting. We'll make it work.
it's like a radio show, and you may want to count your blessings. But anyway, my concern is a couple of things, and I first want to say that in this country, and indeed in the world, there is an epidemic, and I'm not talking about COVID at the moment. There is an epidemic of worrying about dementia that is maybe 20 times bigger than the actual epidemic of. And if I have just described to you something that is inevitable in our lives, and it will happen to us at some point in every one of our lives if it gets long enough, and we can forestall it by taking as good a care of ourselves as I can, as you can, then it's pretty hard for me to say that I have described a disease. If I have joints that are 75 years old, and I've walked and I've run and I've climbed mountains and jumped out of airplanes and done a lot of stuff to injure those joints, nobody's surprised that I limp around a little. When I have 75 years worth of memories and experiences, and it takes me a little bit longer to sort through that data and answer that question, nobody should be surprised that time on the planet has something to do with that. And if I have trouble remembering something when I'm 75, my first thought is it started, it has begun. If I had trouble remembering that same thing when I was 15, that thought would have never occurred to me. And so if we are talking about a condition that is going to happen, that is a function of time on this planet, that is inevitable, that is not a disease, we have let medicine and big pharma and all of the people who could benefit from this being a disease take control of the conversation, when the conversation might otherwise be, okay, Mel, now you're 78. I notice you don't remember things so well, but I know that Alzheimer's disease or dementia affects every part of your brain. Mel, you're starting to have hallucinations now. Or Mel, you keep repeating yourself. You're 79 years old, you're 80 years old, and you can't find your hat. You don't even wear a hat. If it's understood that, as Regina said about her dad, we will lose capacity as we get older. There are things I know I can't do with my joints that I used to be able to do. There are things I know I won't be able to do with my brain. I just don't know what they are yet. And if you celebrate me and pay attention to what's important to me, because we all have the same things that are important to us. We want to be secure. We don't want to fear for the next meal. We want to have a place to stay. We want to be loved. But how we want that and how we ask for it and how we express it as we become more with dementia may change. And if you will celebrate me and I will celebrate you for the things that you have that are left, that you can do, the puzzles you like to work on, the painting you like to do, the things that you enjoy, the places you want to go that give you joy, and not so much on the things we lose, we would probably be doing a far better job of taking care of patients with dementia, as difficult as it is watching their personality, their sense of humor, their personhood dissolve in front of your eyes. Then with all of the medicines that doctors prescribe, all of the commercials you see on TV that will tell you about how you can preserve your memory by taking this expensive medicine forever, and there are no studies to validate it. All of the neurological testing and tests and games that you can play that have no valid support in the medical literature about preserving your brain function or cognition, but you see it advertised every day, and spending more real time with the people who care about the patient, with the patient, and that comes with a very strong footnote. If you look at how long patients with dementia live and compare that with how long their caregiver lives, guess who lives longer? Caregivers are an incredible part of this equation, and they don't live as long on average as the person they're taking care of. There is the problem called dementia. There is the person involved called the person with dementia. There's a person behind them calling all of the people who take care of that person. And behind that is called how we interact with each other. There's my dog. How we appreciate what's going on with the person, how much we can empathize and put ourselves in their place and understand, and even with a loss of capabilities, the capabilities that are less, ideally, as Regina said, can become deeper and more profound and a more personal connection with your dad, your mom, your brother, your sister, your kid who has this disease than you maybe ever had with them before in your life. But the answer so far is not any medicine we can prescribe, not any treatment or medicine you'll see advertised on TV. Don't waste your money. It's time spent learning who this person is every day and what we can do to help them and how anxious they are to help us if we can show them what we need in a way they can understand. So I think I'm going to stop for right now. I know I have written questions and I don't know how much time I have, and I'll take any questions from the audience.
Okay, I'm gonna find out now, Mel. That is extremely interesting as far as the information that you provided is really, I wish I had heard you when I was taking care of my dad too. It's a roller coaster. I think a lot of the people also in the audience, Mel, the caregivers and the time burden, the emotional burdens, the sort of financial burdens that come with caregiving are also issues, because it doesn't just impact the person who's being cared for. The caregiver has a sense of being alone, and there are a lot of resources out there. So I think that's maybe some of the directions the questions are going to go. I can forward questions to you. If you've got some questions that were sent to you, correct?
I do.
Okay. You want to read one off and give us an answer?
So sure, I have several, and there are some legal and asset questions, and I'm going to stick around and listen for the answers too, but I will not attempt to answer those. I don't know how to talk to a person with dementia. I need suggestions, and I'm going to refer you to that on a book that I love, and it wasn't one of the ones that was mentioned earlier. It's called Dementia Together. And it was written by a professional caregiver. She is a professional caregiver in the sense that that's her job, but she's not a member of the medical or nursing profession. And she talks about how to communicate with patients with dementia using what's called, and many of you will recognize the term, nonviolent communication. But it's communication that is non-judgmental, that accepts that everybody has the very same basic universal needs. It's a question of how do we communicate when you are walking with somebody and you're walking on a linoleum floor and they come up to a black square of linoleum and stop dead in their tracks. And you look at him and then he's looking at the linoleum and you're thinking, what is going on here? And finally he says, I don't think I will fall in that. And then he steps on it and you keep going. You suddenly realize the world that they're dealing with and what they're thinking about is a different world with different perceptions, and it makes perfect sense to them. But you don't know what to do when you see it. And that's just one of the many examples that she gives of how to be able to connect and understand and enter their world, which is rich and informative and shows you where they are and what they're dealing with and what you can do to help. So Dementia Together, How to Communicate to Connect is the name of it. It's a wonderful resource to help you talk with a person with dementia. Second question I may have already addressed. These are from the January 12th session. I seem to be forgetting things and it feels like something's wrong. Is this normal aging or dementia? How can I find out? Good question, and it again speaks to the avalanche of people concerned about whether they're on the slippery slope of developing dementia. Well, if you're alive, you're on that slope. The question is how high is the angle at which you're sliding into it, and some of us it may be a higher angle than others, but we all forget. There is a condition called pseudodementia. The other word for that is depression. When people get depressed, they forget. They don't make quick memories. They don't keep their memories. They forget what it is. They're distracted. They have 100 other things to do. When they're not depressed, no, it's not even an issue. There are other diseases, and this gets at another one of the questions, like for instance, lupus can cause so many systemic problems that it can affect your thinking. There are a multitude of connective issues and Parkinson's and other things that can affect your thinking in a way that it does become an issue of, is there some part of this that is dementia? Number one, I would say maybe not, and there are ways to sort that out and tease it out. There are psychological testing and ways to see how much of the struggle that I'm having with my mental status is anxiety, how much of it is depression, how much of it is actual cognitive decline. And if so, what are we going to do about all of that? And unfortunately, the cognitive decline part, I've already told you what you can do about that. Stay as healthy as you can and take care of yourself and stimulate your mind as much as you can. But that also applies for the other things too. Where can I get tested? So that's a huge question in a layperson's mind. It's not so much in a doctor's mind. And the other thing is, another question that just came up recently, it's been suggested by our primary care doctor that one of us should have a neuropsych examination, and our insurance company doesn't accept it. Do we need it? Do we want it? It costs $2,000. We can't afford it. What do we do? A great question, but back up a little bit and ask yourself, yeah, I will send somebody for neuropsych testing if there has been a decline in their performance. If it is significant, it's interfering with their day and their life and their driving and their thinking and their job and their travel and their relationships. If I can't figure out what it is. If I want a neuropsychologist to tell me how much of this is anxiety, how much of this is depression, how much of this is dementia, how much of this is the fact that they had a grade school education, how much of this is due to what, then neuropsych testing can parse all of that out. And if you've ever had it or ever gone through it, it's interesting because it's about you. And it tells you your IQ, and it tells you what you're good at, and it tells you what you're not so good at, and how anxious you are, and whether we should consider an antidepressant, and have you had a cognitive loss. But the problem is it can't answer a lot of those questions till we do 1 or 2 or 3 of them a year apart. Then I can tell you your trends. I can say, you know, you performed at this level in 1993 and this level in 1995 and this level in 2001, and here is a trend. So don't overestimate what this kind of testing can add for you. There is a article that I've seen several times quoted in the last week in the newspapers about ways that you can tell if you're going to have dementia 9 years from now. You may have seen that. And in essence, it's exactly the same thing. These are subtle, common tests that we use to see, because Alzheimer's just doesn't affect your memory. It just doesn't affect your recall. There are examples of dementia called frontotemporal dementia, where people have great recall, but their personality changes. And they're suddenly a very, very different person than they ever were before. Their behavior changes. They're doing things that are uncharacteristic. And it is a form of dementia. It's just in a different part of your brain. So there are tests, yes, that you can do that look at cognitive decline, that look at how well you can repeat a drawing, that look at whether you can remember 3 words 5 minutes later, that look at how creative you can be. And yes, they will over time predict those people who are more likely to be demented, or to have dementia. It isn't really a be demented anything, it's having dementia, but it cuts a fairly large swath, which I mean to say, if you skate through those and you do fine, okay, you're good. But if you have some issues with that and some problems with that, that doesn't mean that you're headed down that slippery slope to dementia. That just means that you may be having some issues in this problem. Maybe more definitive testing is needed, or just maybe more time. Give it time and it will declare itself. It's not going to go away. The other, is it essential to get a diagnosis? It would be absolutely critical to get a diagnosis if I could do anything about it. It's important to get a diagnosis if I'm driving and I'm making mistakes and it's not due to my hearing and it's not due to my vision. I'm making bad decisions and traffic out there is a killer. Yeah, it might be important to know. If my job depends on it and I'm an air controller, yes, you want to know if I have dementia or not. But Is it essential to get testing for it? In my view, no. There isn't a primary care doctor in Green Valley that can't diagnose dementia with a fair amount of certainty. But I cannot look you in the eye and tell you that you have Alzheimer's disease and know that I am 100% right without a brain biopsy. Not many of my patients want that. So I can tell you, you've had these cognitive changes. They've been going on for 7 years now, and your daughter first noticed that then, and your world is becoming more confined, and your decisions are less authoritative, and you don't have the interest you have, and I don't think you're depressed. So I do think that you probably have senile dementia of the Alzheimer's type is its official name. But I can be right about 95% of the time. I can't be right 100% of the time without that piece of brain tissue that shows those plaques and tangles that Alzheimer's showed over 110 years ago. So it is not, sometimes in the early stages, it's not so easy to tell. There is a condition you may have seen on television called mild cognitive impairment, where you start having exactly what it says. You don't remember things as well as you used to, but part of it is it may not be as important for you to remember them as well as you used to. So yeah, I heard it, but I don't care to remember it. About 10% of people with mild cognitive impairment go on to develop Alzheimer's disease. That means 90% do not. They cruise along at 70, at 80, at 95. They have mild cognitive impairment. They don't learn things as quickly as they learn, but they still learn. They remember stuff, they do stuff, they keep a schedule, they look at the calendar, they pay their checks. They have mild cognitive impairment. 10% of those at some point in their lives will have a diagnosis of dementia, 90% won't. So, and how can I help a friend in a memory care center? Be with them, share your issues with them, read this book, Dementia Together, and find out what they're afraid of and what they're interested in and what they would like to happen in the way they would like for it to happen. And that would help a lot.
Mel, can I field some questions from the audience?
Yes, ma'am.
Sure. Okay. Does anybody have a question? I will repeat it. Questions of Mel? Yes. Okay, give me one. Okay.
They're all
Okay.
quite and something, according to the doctors, maybe dementia. All the medicine they put her on, either cause her seizures, or do no good. She was in the hospital 3 times because of medicine that she was given for dementia. And I picked up right away that the medicine was causing the seizures. So how do you decide what kind of medicine that you can or cannot put her on?
Okay, Mel, I don't know if you heard that specific question. This gentleman has a wife who has, the doctor suspects Alzheimer's, or excuse me, dementia, and put her on a series of medicines and resulting in seizures, and she was hospitalized. Comments on that?
Without knowing the medicines and the doses, it would be difficult to comment on it, but I will tell you that doctors are conditioned to try. And there are medicines, probably 4 out there, Namenda and Aricept. There are others, galantamine, that are approved by the FDA for, and I'm going to talk about some other things in a second, by the FDA for treatment of dementia. If you ask a geriatrician or a neurologist the question, does it change the course of the disease? The answer will be no. There isn't a medical study that says that it changes the course of the dementia, any of them. Now, if you're taking your boards and it says, what medicine would you start a patient on with dementia? you would say Aricept. And if it said, and the patient had moderate or severe dementia, what would you start them on? And you would say Mementi. This is out in the literature. It is what we do. It's what people expect. It is the doctor's effort to not appear like they're doing nothing. And there are, like I said, with Aricept, there are a few people who actually do seem to benefit. And I can't look at you and tell you if you're that 1 in 10 persons. The only way I know is to try it. So what doctors will usually do is start you on 1, maybe 2 medicines, see how you tolerate it, see if it makes a difference. If it doesn't make any difference, you stop. Now, there have been 2 new medicines approved by the FDA in the last 2 years. One just came out, one came out about a year ago. These are IV medicines that you have to take every month. They chopped the price from $76,000 down to $56,000 a year. The committees that look at these medicines recommended to the FDA to not approve these medicines. The FDA approved them both. The chairman of the FDA, who approved them both, will be working for one of the companies that makes these medicines in the next 2 years, I guarantee it. But the medicines cause microhemorrhage in the brain. They do kind of magically make the plaques that Alzheimer's described go away. They do that. They do not change the function of the person taking the medicine 1 whit. So it causes microhemorrhages in the brain. It causes possible side effects or problems. The FDA has approved it. Medicare has not approved it and won't approve it because of the side effects and because the committee to the FDA said, don't you dare, and they did anyway. So you're going to see articles about both of these medicines and watch closely for the disclaimers. And I have to admit, if I am watching my beloved wife deteriorate with dementia, I will try anything. I will spend anything. But I need to know what the facts are. And those are the facts. A lot of controversy about these new medicines because there are billions of dollars to be made. There are Nobel Prizes to be won if you can find the answer to this enigma. And to say the answer is something like, take care of yourself, do what we told you to do all your lives. Pretty boring, but it's the only thing that's been shown to make a difference. Why she had seizures, I don't know. A lot of patients with dementia have seizures. A lot of patients with dementia have Parkinson's. A lot of patients with dementia have delusions and hallucinations. So it may simply be a part of her dementia. It may have to do with the medicines.
Other questions? Yes, ma'am.
I have a question related to medicines. I have a question that's on the same topic of the medicines. And I think you said donepezil and Aricept are the same thing.
Yes.
And that it's been around for 30 years. Do you know if of the interactions with other drugs? Do you know of interactions with other medications that the person might be on, like tramadol or trazodone, for example?
The first 2 that you mentioned, Aricept is okay to take with those, and there isn't much interaction. Aricept on its own can do some interesting things. It can cause tremor. It can cause insomnia. It can cause tachycardias. And in 1 person out of 10 that tries it, it can cause their dementia to kind of settle down. So if you are informed about it and your doctor talks to you about the side effects of it, a lot of people won't even start it. But if they start it, you start at a low dose, 5 milligrams a day. You take it up to 10 milligrams a day before you can say, okay, this is a dose that's supposed to work. Does it do anything? And if 4 weeks later, 6 weeks later, 8 weeks later, you haven't noticed any difference, you can stop it. Now, if you stop it and they obviously decline, you can start them right back on it. But and you will not have lost anything. They'll go back to where they were before. But in terms of interactions with other medicines, the problem is everybody's so different. When you get more than 8 medicines that you're giving a person, which is maybe average, there is absolutely no way you don't have an interaction with 1 or 2 of those medicines once you get to the magic number 8. But Aricept is not terribly notorious for being a medicine that reacts awfully with other medicines, but go to the website, look at it. I'm sure there are medicines you wouldn't want to give it with.
Another question? Yes, sir.
I see a lot of over-the-counter stuff advertised.
Right.
That is Prevagen. Is he saying those are?
Okay, the gentleman wants to know about over-the-counter memory / Prevagen / there are a dime a dozen on infomercials. Any comments on that, Mel? You know, the over-the-counter memory boosters?
Number one, I wish they were a dime a dozen. They're not. And number 2, they are a waste of your time and money. Take Tai Chi lessons, play golf, do something else with your money.
Questions more? Yes, ma'am.
Is there an aid for the insomnia?
Is there an aid, did you say? Oh, aid for insomnia? Mel?
Entirely different topic.
Yeah.
And if you,
Oh, a patient with dementia and insomnia, is that? Doesn't sleep. The patient doesn't sleep.
so a couple of things on that. We'll talk about insomnia for a minute. Number 1, if they're on Aricept, just remember insomnia is a side effect of Aricept. Number 2, if I am 18 years old and I get 6 hours of sleep a night, when I'm 80 and I'm healthy, I will probably get 6 hours of sleep in 24 hours, but I'll go to sleep at 10, I'll wake up at midnight. I'll read the Reader's Digest for an hour, I'll go back to sleep, I'll wake up at 1, I'll look at my computer, I'll go back to sleep, I'll get up at 5. I'll nap during the day, and if you add all of those minutes together, voila, you get very close to 6 hours. It isn't all at once, it isn't restful, but that is the way our sleep patterns change as we get older. Now, I personally am of the conviction that if you get up during the day and you stay busy and you do stuff and keep your mind busy and you're exhausted by the time you go to bed, you can pretty much get your 6 hours in all at once. But having said that, that's kind of what happens to all of us in a minor way as we get older. Then for patients with dementia, it gets a little difficult, because if I work for the railroad and I work nights, good luck getting me to sleep nights. But assuming that this is a person who gets up in the day and goes to work and comes back and goes to bed at a decent hour and gets up in the morning and goes back to work again all their lives, then what you would try and do is do your best to see that they're awake during the day, all day long. Interrupt them if you have to, wake them up if you have to, so that when their head hits the pillow, they want to sleep. Number 2, if they're going to go to sleep, they have to be in a room that's quiet. If there is noise that bothers them, you have to get a source of white noise. So the little machines that make noise, that sort of mask the noise. You want the rooms to be dark, but there has to be enough light that they can see to make it to the bathroom. It needs to be cool, because people sleep better when the room's a little cool. You do all of the things for good sleep hygiene that you would for any of us to try and help us sleep. In terms of medicines, Benadryl has been used for medication to help people sleep. It's what's in Tylenol PM. Girls can take it, but it makes all of our mouths dry and it makes us want to fall down. Boys can't take it so well because it interferes with their prostate. Antihistamines will do that. So Tylenol PM might work better if you're a female than it is if you're a male, but they're both associated with an increased risk of falling down in the middle of the night. The other medicines that are frequently used are melatonin, because melatonin mimics an enzyme that happens in your brain when it's bedtime that kind of says, hey, time to go to bed. And if you take that pill about an hour before you go to bed, it tells your brain, hey, it's time to go to bed. And it has very little in the way of side effects. And you start at 1 milligram a night and you gradually increase it up to 6 or maybe 9 milligrams, and then you don't go any higher than that. The other thing that is frequently used is tramadol. Tramadol is an antidepressant. If I want to take tramadol as an antidepressant, I've got to be taking like 300 milligrams a day. If I want to take tramadol as a sleep aid, 50 or 25 milligrams a day will do that. Tramadol helps pain. It helps depression. It helps you sleep. So it kind of comes down to tramadol. I'm saying tramadol, but I'm not trazodone, not tramadol. Tramadol is Ultram, and that's a narcotic. But trazodone is the antidepressant that you can take in low doses to help you sleep, have less pain, and help a little bit with depression, but it's a very low dose to treat depression. So those are typically the three things: the Benadryl, the melatonin at the right dose, and the trazodone. Now, other sleep aids all have a side effect, and they are the category of medicines most associated than any other medicine with falls. So if you take Ambien, you're going to fall more. If you take Restoril or Sonata, any of those sleep aids, they'll help put you to sleep, but when you get up, your blood pressure will drop in your socks and you'll fall down. And that's why people are scared to death of those. And even more than narcotics, even more than blood pressure medicines, even more than antipsychotics, that category of medicine is associated with falls and injuries. So that's why your doctor is going to be reluctant to prescribe those for you until you've tried everything else.
Okay, Mel, listen, we're running out of time here. I know that they're going to have if there's any more questions, I want to thank Dr. Hector for joining us today. And I'm looking forward to directing one of his plays. So it's wonderful. So I'm really looking forward to it. But Mel, thank you so much. And I'll see you at rehearsal.
Very much, and thank you, Regina, and thanks everybody here. I appreciate your attention.
Okay, bye-bye.
Bye-bye.
Well, thank you very much. That was very helpful, very strong, a real clarity that, you know, challenges us as a community to say it's ours to do. Caring for each other, finding ways to build a team so that we're not just isolated in our caregiving. And that's a real key. Next week, we do have Linda Laird with us. She is a person who cared for her husband with dementia through 7 years until he passed away. She tells her story. And part of the reason I wanted Linda to be with us is because she is very direct, also has a proclivity of, what's the right word? She reads a lot. She is really well read. And so she will come not only as somebody who has her own experience to share, but to open it up to others and also to share insights from a lot of other people. As I mentioned at the beginning, you're welcome to mill around, stay in a group, talk together. Also, if you want to be on the mailing list, make sure we have your email address, your name. And if you're interested in that virtual experience about what it's like to have dementia, sign up for that over on this table. And Chris, one more.
That I have never seen one of those clipboards that was being passed around, so I imagine a lot of people haven't. If whoever has them could bring them to the table, we can all use them there.
Make sure we sign up on the clipboard, on the registration. Anything else, Marge, or anybody else today? Regina, thank you so much for your help today and for being with us. We'll see you all next week.